hypoglycemia. The topic for my lecture today is hypoglycemia, and it is actually a common problem encountered in pediatric practice, and more so in neonates, actually smaller babies compared to older children. So it's more common in neonatal units, but in the pediatric units also we come across certain children who are having these problems, hypoglycemia. So Indranila, why is it not moving?
Sir, I think there is a lag in signal. So, have you moved it through this cursor?
Uh,
Should be moved as a normal slideshow, sir.
right. So right. Okay. Sorry about that.
Moving,
So
sir. Moving.
now you can hear me, no?
Yes, sir. We
Yes,
can
sir.
hear.
Yeah. So objectives of my lecture, or the lineup of my lecture is like this. So I'm going to start with the introduction, and we'll start with some case histories. Actually, these are patients we have managed in our neonatal unit over last few weeks, and then we'll discuss about clinical features. I hope you all have seen these children with hypoglycemia, and you must be knowing their clinical features. And what is important is these clinical features are not specific for hypoglycemia. Children with other problems can present with this sort of clinical picture. And definition is also a bit of an issue. There's no agreed definition actually. So various sources give slightly different definitions, and incidence in large babies and IUGR babies, and about the etiology and diagnosis and possible differential diagnosis, and about most importantly about management and about the prognosis of these children who had hypoglycemia. So I'll start with the case history one. So what I would like you to do is, you can I have given 3 questions at the end. You can type your answers in that chat box. So then we can discuss, right? So the case is, term twins were delivered by elective section, and T1 had a weight of 2.2 kilograms, and T2 weight was 1.7. So this T2 is some smaller baby, and T2 became jittery on day 1, and when the blood sugar was checked, it was very low, that is 25 milligrams per deciliter. And there is no history of maternal diabetes mellitus or gestational diabetes mellitus. And this T2 was admitted to PBU for the control of blood sugar levels, and he was started on IV 10% dextrose drip, and we have also continued that NG feeds. So first question is, what are the possible causes for hypoglycemia in T2? And second one is, what further investigations would you do on this baby? Third question is, what other steps you could take to control the blood sugar levels? So I'll give you 1 minute. If you can quickly type some answers in the chat box, we can go ahead and discuss them. Okay, shall we discuss the answers then? First question is, what are the possible causes for hypoglycemia in T2? So this, as you can see, this T1 is quite, again, it's not normal weight, but slightly bigger than the T2. So this T2 seems to be having IUGR, or it's a small baby, and it may be the most likely cause for the hypoglycemia, where he's having low stores, low glycogen stores, right? So what further investigations would you do on this baby? So investigations, actually mm, uh, you can divide into two, basically. One related to the hypoglycemia. So as you know, if a child is, or a neonate is having hypoglycemia, we have to confirm that hypoglycemia. So we are usually in the neonatal units and in the wards, we are using our this capillary blood sugar monitor or machine, glucometer. So actually, to check blood sugar levels in neonates, there are specific neonatal glucometers. So that I don't think we have in Sri Lanka at the moment. Uh, if we use this glucometers used for adults, so it will not give a accurate reading in neonates, right? One reason being their sugars are usually bit on the lower side. So the always when we get a glucometer reading, low reading, always we have to confirm it with the lab sample. We have to send a sample to the lab, but we should not delay the treatment of that child, especially if the child is symptomatic. We have to treat them, but always it's very important to confirm that low blood sugar reading we got from the glucometer with the lab value. And with that, we can say another investigations related to hypoglycemia, like insulin levels or cortisol levels, so free fatty acids or whatever. So we'll discuss about them later. Uh, and so what other investigations, we can do a septic screen, blood cultures, counts, CRP, and so on. So that's the answer to the second question. And what other steps you could take to control the blood sugar levels? To what we usually do in our neonatal practice. So if a child is having, if a neonate is having hypoglycemia, so we start them on, usually we start, if it is very low, we have to give a bolus of dextrose, 10% dextrose, uh, 2 ml per kg, or some say like you can go up to 2 to 4 ml per kg, followed by a drip. Always you have to follow it by a drip, otherwise they can get rebound hypoglycemia. Then what you can do is, if the sugars are not maintaining, you can increase the fluid you are giving, that is to the uh, next day amount, right? So but still, if it is coming down, if the sugars are coming down, then in that case you can go for higher concentrations of dextrose, like 12.5% or 15%. But if you are giving higher concentrations, you need a central access or umbilical line, right? So apart from that, there are other drugs we can use, uh, like hydrocortisone, glucagon, and so on. So we'll discuss about this later. This is the continuation of the same clinical history. As he continued to have low blood sugar readings, he was started on IV antibiotics. On day 3, he developed breathing difficulty, started on nasal oxygen. His blood gas showed severe respiratory acidosis, and the baby had to be ventilated within couple of hours. And he showed bleeding tendency when bloods and cannulations were done. and also there was some blood at the intubation, right? And there was also a coffee ground aspirate when the NG tube was inserted. So, what are the possible reasons for the above deterioration? So, if you can quickly type the answers in the chat box, and what further actions would you take when managing this baby? So if you can, I'll give you 1 minute. You can quickly type your answers. We'll go for the discussion. So by the way, if you have any queries about presentation, if anything is not clear, you can also type that in the chat box. So we can discuss them at the end. Right. So shall we discuss then? Uh, so what are the possible reasons for above deterioration? So you can see from this history, this child is like seems to be having sepsis. As a child is septic now, and other possibilities, child developing necrotizing enterocolitis. So that is the reason. So in this sort of a situation, you have to be careful, like when you are giving various drugs to control the blood sugar levels. For example, in a septic child, if you are going to give hydrocortisone, that could be a problem. And next question is, what further actions you take when managing this baby? Uh, so obviously you have to escalate your antibiotics maybe to the third line. This is very ill baby, and then because of these bleeding manifestations, uh, you might have to start them on vitamin K, antacids, and then you might give blood transfusions and FFP, etc. Mm, right. So with that, we'll move on to the next case. So case history 2. This newborn baby was noted to have ambiguous genitalia at birth. So this one also was in our postnatal ward a few weeks back. And so what investigations you would do on this baby and how do you treat? Again, if you can type your answers in chat box, then we'll go for the discussion. So this is another situation where they can present with problems with sugar hypoglycemia, right? Okay, right. So we'll discuss the right. So what are the investigations you are going to do? So here anyway you can go back and so this child you can see there's clitoromegaly and there are like labioscrotal folds are there and there's no vaginal orifice and it's also having uh, pigmentation of the at the axilla. So this sort of a child, then you have to confirm whether this is a virilized girl or whether it's a boy. So because of that, we have done some investigations. Investigation was electrolytes and blood sugar levels. We had to do initially and repeat it on the second week, because as you know, if it is a soul losing type of congenital adrenal hyperplasia, they will present to you in the second week, right? So ultrasound scan of the abdomen we have done on this child and pelvis, which showed female internal genitalia. There's a uterus, but the gonads were not clear in the scan. Uh, and and by the way, like on the examination, the gonads were not palpable in the labioscrotal folds. And uh, we checked 17 OHP levels, which was found to be very high. So that confirmed our diagnosis, and we managed this child on hydrocortisone, fludrocortisone, and this sodium was in the lower side. We had to, later on we had to add sodium chloride 3%, and we have discussed with the endocrinologist, pediatric endocrinologist, and also we have arranged pediatric surgical referral for genitoplasty. So with those case histories, we move on to the presentation introduction. So as I mentioned earlier, hypoglycemia is one of the most common metabolic problems encountered in pediatric practice. Definition, clinical significance, and management are controversial. So there's no standard definition, and so on. Various sources give slightly different definitions. And blood sugar glucose levels are frequently lower in the newborn babies, and interestingly, they can even tolerate these low sugar levels. And after the delivery, around 2 to 3 hours of life, the blood sugar level in the baby drops to a very low level, and then it will go up, right? You have to interpret these results or sugar values with the clinical context. So what are these clinical features of hypoglycemia? Symptoms actually can be mainly divided into two. One is like due to sympathetic stimulation. So they can have this sweating, tremor, palpitations, pallor, tachycardia, and weakness and hunger. So they are called neurogenic symptoms. And other symptoms are due to lack of oxygen, lack of glucose to the brain. So as you know, the brain gets uh, sugar or glucose through facilitated diffusion, whereas other muscles and other organs, like when they, insulin is involved, but in the brain there's no involvement of glucose. So as a result, when the glucose level, as a result, when the glucose level is very low, uh, there will be less glucose delivered to the brain. So these other symptoms are called neuroglycopenic symptoms. That is due to lack of glucose to the brain. They include lethargy, confusion, irritability, and loss of consciousness, and even seizures. So older children and adults will demonstrate what we call Whipple's triad, which we will discuss later. And symptoms in infants and toddlers are frequently non-specific and include irritability, lethargy, poor feeding, cyanosis, and tremor. So sometimes infants will not manifest any symptoms, and all of a sudden they can throw a seizure, hypoglycemic seizure. So as I mentioned earlier, so all the clinical features we discussed earlier could be due to other problems, other causes, right? So more about definition. So hypoglycemia is defined clinically as a plasma glucose concentration low enough to cause signs and symptoms of brain dysfunction or neuroglycopenia. The threshold for confirming a diagnosis of hypoglycemia and for obtaining a diagnostic sample is less than 50, and some authorities take it as less than 45. And so this is the Whipple's triad we were talking about earlier. So what is this Whipple's triad? That is reliable measurement of a low glucose level. So as I mentioned earlier, so you can do a glucometer check and confirm the low value with the lab reading. And then signs and symptoms consistent with hypoglycemia, right? So child is having signs and symptoms we discussed earlier, and once you correct the blood sugar glucose level, child comes back to normal, and signs and symptoms will resolve, right? So that confirms our diagnosis. And if the child doesn't recover after correcting uh, glucose level, then you have to think about other possible causes. For example, child who had a prolonged seizure can have hypoglycemia. So there can be associated with other problems, like maybe a septic child will also have low blood sugar value, right? What is the incidence? So it's around 8% in large babies and around twice high in small for gestational age babies. So how do we evaluate these children when they present with hypoglycemia? So it involves obtaining a critical sample. That is like at the time of hypoglycemia, we have to check the like hormone levels and other fuels involved in the glucose metabolism. So it's very important. You have to do this test when the sugar levels are low, right? So you can take it like at the acute stage also, uh, only if the child's mental status is normal, or otherwise you have to fast the child again later and take the necessary samples later on. Uh, so then depending on those lab findings, then we can narrow down our diagnosis. So this we can narrow down narrow down our differential diagnosis or categorize them by measuring these levels of lactate, ketones, and free fatty acids. So etiology. So what are the etiologies of for hypoglycemia? So we can broadly categorize them into three. One is due to increased utilization of glucose or hyperinsulinism, or because of decreased production or stores, as in a child with IUG or preterm baby. Or then there's other categories where there's a mixture of increased utilization plus decreased production. So first we'll discuss about increased utilization of glucose. So increased utilization of glucose or hyperinsulinism is seen in babies of diabetic mothers and large for gestational age babies and erythroblastosis, and problem is in the pancreas, like islet cell hyperplasia, hyperfunction, and so on. And also there can be insulin producing tumors. And I hope you have heard about this Beckwith-Wiedemann syndrome, where there are like macrosomic babies who have very difficult to control hypoglycemic episodes. And then maternal treatments like propopamide, thiazide diuretics, and misplaced umbilical artery catheters. And if you stop the high concentration of glucose abruptly after exchange transfusion, and as an exaggerated response to neonatal transition. So then, can you identify what's wrong with this child? Hmm? If you can type your answer in the chat box. Hmm? What is wrong with this child? Right. So this is the this is a baby with Beck-with-Weidemann syndrome. We discussed earlier. They have this large tongue, visceralomegaly, and then they can have hemihypertrophy. So you can observe that this uh, left lower limb is bigger compared to the right side. And then they're not to have these transverse ear creases, right? So that is Beck-with-Weidemann syndrome. So decreased production is seen, and associated hypoglycemia is seen in conditions like prematurity and IUGR, and inadequate feeding or calorie intake, and if there's a delay in onset of feeding. And there are other list of causes where you see both in combination, increased utilization plus or minus decreased production. Those examples include perinatal stress, exchange transfusions, defects of carbohydrate metabolism, for example, glycogen storage disorders, fructose intolerance, galactosemia, and then it could be due to endocrine problems like adrenal insufficiency, congenital hypopituitarism. Mm. So, so children, you must be knowing that children who are having midline defect, so like cleft palates and hypogonadism, then we have to think about hypopituitarism, congenital, uh, and defects in amino acid metabolism, pancytopenia, polycythemia, and then maternal drug use like drugs like beta blockers. So this is flow chart, is self-explanatory. So it shows categorization of hypoglycemic disorders based on the biochemical profile. So hypoglycemia, you can see on one arm there's no acidemia, and other side conditions with acidemia. And then in the side of no acidemia, certain conditions present with low free fatty acid levels and low ketones. Examples include hyperinsulinism, insulinoma, factitious hypoglycemia, and oral hypoglycemic ingestion. And with no acidemia and increased free fatty acids and reduced ketones, you get MCAD, VLCAD. And then on the other arm, hypoglycemia plus acidemia with increased ketone levels, you get glycogen storage disorders, growth hormone deficiency, cortisol deficiency, and idiopathic ketotic hypoglycemia, which is quite common. And then with acidemia and increased lactate, you get glycogen storage disease type 1 and pyruvate kinase deficiency. So hope it is clear for you. So a few words about idiopathic ketotic hypoglycemia. It is the most common form of childhood hypoglycemia. So you must have seen these children. Usually they present with usually they were unwell, and they don't get their dinner properly, or their mothers might come and say they didn't have anything for dinner previous night, and then following morning they get this hypoglycemic episode, or even they can throw a conversion, or they can become drowsy, sweaty, and have other features of hypoglycemia. So and actually, so usually they present between 18 months to 5 years, and usually it remits spontaneously by age of 8 to 9 years, and remission is, we think it's due to increased muscle bulk. It happens usually with associated with other intercurrent illnesses. So at the time of this hypoglycemia, if you check this child's ketone urine for ketones, so it will be positive. And to check ketonemia, actually like in UK, when we were doing foreign training, like there's a small device, like it's like a glucometer, and it gives the like do a prick, and you can take a ketone level value, like what you do with the glucose glucometer, right? And plasma insulin concentrations are also low. So, and these children also are known to have low plasma alanine concentrations. So etiology is it's very not very clear. So maybe defect in any of the complex steps involved in the protein catabolism, oxidative deamination of amino acids, transamination, alanine synthesis, or alanine efflux from muscle. So affected children are smaller, and often they give a history of transient neonatal hypoglycemia, and some actually IUGR babies. Right. So treatment includes, so you basically you should not keep them fasting for long periods, right? So before they go to bed, you have to give something to eat. We recommend a high protein, high carbohydrate diet. And it's important, like if the parents can check the urine for ketones, so usually these ketones precedes the hypoglycemic episode. So if you can check the ketone levels, so they can, if it's positive, they can give something for the child to eat, then they'll be okay, right? This is diagnosis of hypoglycemia. So we have discussed these symptoms earlier, and we have to screen some children uh, who have risk factors and others who have symptoms. So Reagent strips we discussed earlier, they have unproven reliability, especially when the neonates have these low values, sugar values, and sometimes they can even tolerate low values as low as 30 milligram per deciliter. And these strip values are like lower than the whole blood glucose. Oh, so sorry, 15% lower than the plasma level. So it gives a lower value. Uh, as we mentioned earlier, discussed earlier, we have to confirm that value with the lab RBS. However, if the strip glucometer shows less than 45 value, then you should not delay. But you can take another sample and send it to the lab at the same time. But you don't have to wait for the lab confirmation to treat that child. So laboratory diagnosis. Uh, so So lab sample also you have to obtain it, and you have to analyze it quickly. Otherwise, if there's a delay in the analyzing, you keep it for a long time in the ward and send it later to the lab. So there's a fall in the sugar levels around 18 milligram per deciliter per hour. Right? So there's a long delay, it will give a low value. And clinical confirmation. So lab determine serum glucose level less than 40 with symptoms will confirm that hypoglycemia. And as we discussed in the Whipple's triad, so prompt resolution of symptoms after administration of IV glucose. Right. So if it doesn't correct the problem, or if the child doesn't become well, then we have to think about other causes for those signs and symptoms. So what are the additional testing on these children? So especially if the hypoglycemia lasts for a long period, like 1 week, or if they need large glucose infusions, large amounts for more than 1 week, then we have to do this additional testing, and we have to get endocrinologists involved, and list of uh, hormones we can check are listed there. Insulin growth hormone, cortisol, ACTH, thyroxine, glucagon, plasma amino acids, urine ketones, uh, urine reducing substances, and amino acids, urine organic acids, and so on. So in UK, when we are practicing there, we have to send take this hypopack, or basically follow that hypopack protocol. That is, if a child comes with a low sugar value, that is not due to not in a diabetic child uh, who's having hypoglycemia. So if any child without any particular diagnosis, if they're presented to you for the first time with a hypoglycemic episode, and then at that time itself we take these blood samples. All right. So these are the bloods we have to take. It comes in a pack. So 1 ml of blood for glucose, and that is bottle A, that comes with the, you can identify that bottle using the color of the cap, and 4 ml of 4 ml of blood for insulin, cortisol, growth hormone, amino acids, and note that you have to send these samples in ice. So that is this yellow one, and then for another 1 ml for intermediate metabolites, uh, and then 1 ml for ammonia levels. Again, this sample you have to send on ice, right? So that comes the purple or lavender color cap. And then another two three spots on Guthrie card for acyl carnitine profile, and also urine sample for organic acid. So all of these were sent on presentation itself. So most of the time you will get a diagnosis once you get the results. So by the way, when you are working in UK, you have to do all these bloods. Nurses are not going to take bloods for you. So you have to do these bloods. Right. So what are the other differential diagnoses we have to think about? Uh, so they include adrenal insufficiency, which we discussed earlier, as in congenital adrenal hyperplasia, maternal drug use, and other organ failures, and then other metabolic abnormalities, hypocalcemia, hyponatremia, or hypernatremia, and so on, and sepsis and asphyxia. So management. So immediate management. Uh, Patients with confirmed or suspected hypoglycemia should treat promptly by administering glucose. So we have mentioned this earlier. So we have to take the bloods for other testing before correcting the hypoglycemia. If the patient is conscious and can tolerate oral fluids, you can give them something to drink, like sugary drink, juice, glucose tablet, or glucose gel. So you get these gel packs in UK, where this is like a toothpaste like tube. You can just squeeze it onto that hypoglycemic child's mouth. Uh, but again, if the hypoglycemia does not improve within 10 to 15 minutes, then that child needs IV dextrose. So anticipation and prevention when possible are the key to the management, for that matter, for any condition in children that applies. So, well infant at risk of hypoglycemia, infants of diabetic mothers should have serial blood glucose levels measured. So, what usually we do is we check pre-feed sugar level in these babies, that is after a good feed. Prior to the next feed, you take that sample, and if it is more than 45, then you can repeat another pre-feed one. If both are more than 45, then you can stop monitoring, right? So other asymptomatic infants who are at risk, you have to check blood sugar within 1 to 2 hours of life. So we mentioned earlier, around 2 to 3 hours time after birth, they will have a quite low blood sugar level. So again, how often to check the blood sugar levels depends on case by case basis, and we expect to have more than 45 milligram per deciliter blood value on first day and more than 50 thereafter. And certain babies who are having low sugar levels as low as 30 can respond to feeds, but follow-up measures are not high enough. Then you have to give IV dextrose infusion. A few facts about breastfeeding. So babies who are breastfed have lower glucose levels but higher ketone body levels. And early breastfeeding enhances gluconeogenesis and increase the production of gluconeogenic precursors. As you can appreciate, like when the baby is in the mother's womb, this glucose is coming through the placenta. But as soon after delivery, so there are so many things happening to maintain this blood glucose level, like gluconeogenesis and glycogenolysis and so on. So IV therapy indications, if they are not tolerating oral feeding, if they are symptomatic, uh, and with oral feeding, if they are not maintaining adequate glucose levels, and if glucose levels are quite low, like less than 25. So urgent treatment, we can give 2 ml per kg, 10% dextrose. To some authorities recommend 2 to 4 ml per kg, and always you have to follow this up with continuing IV therapy, IV dextrose drip. And continuation, so we have to infuse the glucose at a rate of 6 to 8 milligram of glucose per kg per minute. And if you convert this, that is, if you give 10% dextrose at a rate of 86 ml per kg per day or 3.6 ml per kg per hour, it roughly equals this above rate, right? So there, if you want to find out this milligram and ml rates, then you can use online calculators available, so you can type those milligram levels and the dextrose percentage, and then you will get the how much ml per kg per hour. Right. So you have to recheck the glucose level after 20 to 30 minutes, and sometimes you might have to give additional boluses. So if glucose levels are stable, you can continue feeding, and then you can slowly wean off that dextrose infusion. So for most infants, you can if you give usual maintenance fluids for that appropriate day, it will maintain the glucose values. But sometimes some infants who are having hyperinsulinism or infants with IUGR, they might require higher dextrose percentages. So if you're giving higher percentages, you have to use a central catheter like umbilical venous catheter, and then you can gradually uh, uh, tail it off, taper while monitoring the glucose levels. Then slowly you can wean slowly while on oral feeds, while increasing the oral feeds. And then if the sugars are not maintaining, you can add IV hydrocortisone, 10 milligram per kg they recommend. And by the way, like that bolus we mentioned earlier, so 2 ml per kg over 1 minute, and some authorities recommend it to be given over 5 to 15 minutes. So hydrocortisone dose wise 10 milligram per kg in 2 divided doses. That is if infants are requiring more than 12 milligram of glucose per kg per minute. So how does it act? It reduces peripheral glucose utilization, increased gluconeogenesis, increase the effects of glucagon. Again, before administering IV hydrocortisone, you have to send blood for glucose, insulin, and cortisol levels. And if you don't suspect a metabolic defect, you can continue your breastfeeding or formula. So, a few things about some other drugs we use in hypoglycemic babies. Glucagon is one of them. It can be given IM, but only for babies with good glycogen stores, not in IUGR babies or preterm babies. But it's only a temporary measure uh, to mobilize glucose for 2 to 3 hours in an emergency situation. Then after that, glucose level will gradually drop. And diazoxide, so it's another drug we can use. It can be given for infants who are persistently hyperinsulinemic. It inhibits the insulin release by acting as a specific ATP sensitive potassium channel agonist in the pancreatic beta cell, right? However, it takes around 2 to 3 days to act. And other treatments wise, octreotide, which is a long-acting somatostatin analog, and epinephrine and growth hormones are used rarely. And sometimes we might have to do a surgical subtotal pancreatectomy, especially if they are having an insulin secreting tumor. Additional evaluation. So most hypoglycemias will resolve within couple of days, 2 to 3 days. But if they require more than 8 milligram per kg per minute of glucose, uh, that means the child is having hyperinsulinism, and then and if it lasts for more than 7 days or more than a week, uh, endocrine evaluation is necessary uh, to rule out excessive insulin secretion, maybe due to a insulin secreting tumor. So if you do insulin level in this child, so uh, at the same time you will see you can detect inappropriate secretion of insulin. So then if the insulin level is normal for that blood glucose level, then you have to look for other causes like glycogen storage disorders, endocrine deficiency, defects in amino acid metabolism, and so on. So these evaluations, sometimes you might have to lower their blood sugar levels to very low levels and send this blood for insulin, cortisol, and amino acids. And for some disorders, there are genetic testing is available. What is the prognosis? What will happen to these babies who are having low blood sugar levels? So most cases of hypoglycemia are transient and respond rapidly to treatment, and usually they have a excellent prognosis. The ones who will have problems are the ones with persistent hypoglycemia and ones who are symptomatic. For example, who had babies who got convulsions due to hypoglycemia. But we don't have very clear data, and we don't know exactly at what glucose concentration level they will have this permanent damage to their brain. And then studies have shown these children who had transient neonatal hypoglycemia, as I mentioned earlier, they can get ketotic hypoglycemia later in life. So that concludes my presentation. Thank you very much for patient listening. And if you have any questions, I can answer them.
Doctors, do you have any questions for sir? So
Can't see any questions. Yeah.
No, sir. We haven't seen any questions, sir.
Right. Okay.
Okay. In the absence of questions, sir, thank you very much for your very informative lecture, sir. Thank you for your time.
Excuse me, Maya. Someone has raised the voice. I think Dr. Ajita. Oh,
okay.
Excuse me, Doctor.
Yes.
Have someone asked a question? Hello.
Dr. Rajita, did you ask the question, madam?
Hello. I think it's not.
No, no.
Yeah. Yes.
Okay, sir. Thank you, sir. Thank you.
Okay.
I'll
Thank
upload
you very
this
much, Indranil.
to YouTube, sir. Thank you.
Okay. Thank you very much. Good night.
Good night, sir. Thanks.
Good night.